with improving maternal mortality and newborn mortality. And the reason we're having this conversation today is because the network is asking us to move even faster. So you can see the very ambitious goal of the network, both for maternal mortality and newborn mortality in the next 5 years. Sorry, could somebody mute?
Yeah, we're gonna mute everyone again and unmute you.
Thank you. Okay, I'm assuming I'm unmuted.
Yeah, we can hear you.
Good. So our two big goals, remember, are to reduce maternal newborn deaths and stillbirths in the 9 participating countries in health facilities by 50% over 5 years. A hugely ambitious goal. And also, very importantly, to improve the experience of care of mothers and to make sure that we can actually measure improvement in their satisfaction with care. So 2 very big and important goals. And in order to do that, we're going to have to change the way that the systems are designed. From the previous slide, that if we just carry on doing what we're doing, we are probably going to continue to improve, but not at a rate that's fast enough. So with this quote from Paul Batalden, every system is perfectly designed to get the results it gets. If we keep the same design and the same system, we're going to get the same results. So how are we going to change our system and to redesign it to get better results? So the WHO, and for those of you who were at the Lilongwe meeting, has laid out a simple but important way of sequencing how we think about getting to this very ambitious goal. Starts with a network aim, the 50% reduction, but remember that when you're at the front line, you're going to have your own aims based on your performance. So you're going to be setting an aim, and Nigel and Ashok already spoke about this, the importance of setting a very clear numeric and time-bound aim that describes the particular gap that you're trying to close. We're going to today be talking about the next 2 blocks on this framework, which is the content, and I'm going to show you how we already have a lot of great information at our disposal to develop content, which is the WHO standards and health system drivers, which are the building blocks. And then we're going to talk about the measurement system that informs that performance. And then in the coming weeks, we're going to be talking about our implementation theory, which is the step-by-step country guidance and the 8 elements of implementation. And then, of course, the big differentiator for our network is that we believe that we're going to have to learn our way to full scale. And we're going to talk eventually about this learning system that is going to allow us to make this radical redesign. So for today, we're talking about content theory and the measurement system. So if we look at the sequence, the aim has been set for us by the network, but remember that when you're at the facility level, you're going to be thinking about your own facility aim. In order to get to the 50% reduction and the measurable improvement in mother satisfaction, we're going to have to do something about the care that is delivered at the point of care to mothers who come in for delivery. We have reliable, evidence-based protocols. The WHO has for years provided these protocols. We now, in this process, have to make those protocols reliable. So that's our very first step, and the ideas for improvement are going to be targeted at making that evidence-based care very reliable. So how are we going to do that? Fortunately, we have the WHO standards, which standards 2 to 8, which go directly at the health system elements, which are going to be the drivers of improvement, where we're going to have to generate a lot of ideas in order to make our evidence-based care reliable. So data systems to make sure that we can actually take action, effective referral systems to make sure that mothers don't arrive too late and that they can be attended to if they run into trouble in the peripheral units, making sure that mothers, families, and communities are engaged in their care, making sure that the health workers have the skills and the motivation, and this goes very much to leadership and management aspects, and then finally that there are appropriate resources to do the job. We believe that if we attend to these 5 drivers and focus our energies on making sure that they support reliable evidence-based care, we can get to the 50% reduction. So that's what we're going to talk about today. How do we get these ideas for reliable care, and how do we use the WHO standards on our way to doing that? Then we're going to have a brief conversation about the measurement system. The measurement system is the mirror that we use to tell us how we're doing. So we need to know whether we are, in fact, whether we have good data systems, referral systems, mothers are engaged, that they have the skills and the resources. Very importantly, the measurement system is going to tell us whether we are delivering reliable evidence-based care, and finally, whether we're reaching our outcomes to reduce mortality for mothers and babies, reduce stillbirth. So the measurement system will track. We're not developing a measurement system on the side. The measurement system is very closely tied to everything that we're doing at the front line in terms of improving the health system elements, which are then supporting reliable evidence-based care. So let me take you to a real-life example, just to sort of put this into reality, because so far we're talking very theoretically. So if you see in this case vignette, a 25-year-old first-time pregnant woman is brought to a district hospital by bicycle at midday, and she's already been in labor for 12 hours. The labor ward is very busy. This is a hospital that delivers maybe 5,000 deliveries a month, 30 babies a day sometimes, and she has to wait in line for 2 hours. When she's finally admitted to the labor ward, they find that she's pretty far along. Her cervix is 8 centimeters dilated. Baby seems okay, but they've noticed that there is some meconium, and she's put on a part. She labors for the rest of the afternoon. She makes very slow progress. She's now only 9 centimeters, and she's got some heavy meconium showing. At 8 p.m. at night, the baby is born. It's a smallish baby, 2,000 grams of moderate asphyxia. They can't find the ambu bag, but the baby is given oxygen, is wrapped with a cloth, and is kept in the labor ward for observation. The baby is noted to be struggling to breathe and is transferred to the nursery. He's given some oxygen and is cared for in the nursery. But then the power goes out. The backup generator is fired up, but then it runs out of fuel. The staff are really frantic about this. They're very anxious. Somebody goes to town to try to get more fuel, but the baby gets cold in the meanwhile, gets low oxygen, develops respiratory distress, and then dies before the power comes on. So what I'd like you to do, and this really speaks to the complexity of the problem that we're trying to solve and the range of ideas that we're going to need to come up with. So I'd like in the chat box, if you could just very quickly list the clinical and health system factors that you think need to be addressed in order to solve this problem. So we'll just give you 30 seconds or so. Just type whatever comes, the first 5 things that come into your mind about what are the categories of things that need to be addressed in order for us to solve this problem. So, Benny, I can't see the chat box in this mode, and I'm just going to ask you to maybe just call out some categories, if you would. If you could just call out maybe 10 categories that you see, the first 10 that you see.
The only one I have so far is clinical. That's the only answer I have. Please, people, type your answer to all.
Florence said the 3 delays. Ariane said, Rietsma said the 3 delays. Simon said ready available clinic equipment triage. So we're talking about resources here mainly. I'm seeing a conversation about resources. Okay. I think we could come back to that maybe at the end. And I think the way that I'm going to show you how we analyze a process like that, we can come back to these factors. But I think Florence and others are pointing to other systematic ways of looking at that, which is the 3 delays, preparedness, being ready ahead of time for these kinds of events, which I think gets to some of the health system issues. Okay, so let's just keep moving. So now we're going to focus on this content piece. Remember we spoke about the 2 main boxes of this content piece. One would be reliable clinical processes, and then the second would be the health system drivers of improvement. I would draw your attention to the fact that there is a very rich set of ideas already that the WHO has put together. And if you're not already very familiar with these, I would strongly urge you to do this, because this is an absolute gold mine for frontline providers who are really trying to address the clinical reliability issue on the one hand, which is WHO standard number 1, and the health system support factors on the other, and the engagement and dignity and respect of mothers, which is encapsulated in the 3 of the standards. But if you look at those standards, they are the source material for what needs to happen in order for your processes to become more reliable. So that's the very first important factor. The second is that we're going to talk about 2 frameworks that will help you get to the ideas that you need to help you improve your process performance. The first is process mapping of the clinical processes we'll talk about. And the second is really understanding that each of those health system drivers that we spoke about need to be addressed, and then you need to have some way of understanding how to get to those, to get a better state for those 5 factors that we spoke about. Data systems, care of mothers, attention to mothers, training, well-prepared teams, and resources. So let's talk about the first one, getting us to reliable evidence-based care. There is a very simple way of getting to a map of reliable evidence-based care, which is just to follow the journey of the mother. And if you think about that story that I told at the beginning about the mother arriving at the hospital, that story had a beginning. That beginning of that story was that mother going into labor and getting on a ride on a bicycle, on her husband's bicycle, to be driven up to the hospital. That's the beginning, okay? Then the mother gets admitted. There's a whole lot of early labor. She happened not to be in early labor, but there's an admission process of assessment, triage, making sure that mother's okay. These are all processes that I'll show you that can be mapped. Then moving on to full labor, all the factors that this is a critical time, making sure the mother is observed, and then making decisions, triage decisions on whether the mother gets routine care or emergency care, and so on to early postnatal for the mother and baby, and to the late postnatal for mother and baby, until the mother and baby are successfully discharged from hospital. You can see that this is the way that we organize the processes to allow us to not only get organized and understand, but also, as Ben will show you in a moment, how do we measure each step of the way to make sure that we're getting reliable care. This is how we generate our priority list for what we're going to go after and what the ideas we need for improving that. So the way that the process map works is it follows the patient journey through a sequence of process steps. Each step will include some combination of screening, decision-making, and action. So there are 3 aspects to each one of these steps: screening, decision-making, and action. And the performance of each step can be tracked either by existing or new measures. This is a big issue about the measurements, what measures are available. We'll talk about in a second. And then, if you find a gap, you can then improve those by introducing local ideas, which can then be tested, as you'll see in the next seminar series, okay? Having a common framework across a country, across a district, is very helpful because everybody is then understanding what each other are doing and speaking the same language. This helps us to share our learning and to share our change ideas and to talk about what's working and what's not. So setting this process map up, both at a facility level and a district level and maybe even at a national level, so that we're talking the same language, is hugely important in this process. So this is an expanded map now, which shows the 4 steps: admission, intrapartum. There's a mistake there. That should be early postpartum and then late postpartum. And you can see that for each of these, there's an admission, a routine step, or a treatment step. Okay, so we have the 3 aspects of each step. And what I'm showing here is the range of information, very detailed and granular information that's provided by WHO standard number 1 that will help you. This is not organized according to the patient journey, but in this set of standards, you will find the ideal state for every step of the way, whether it's a routine treatment step, a routine screening step and management step, or whether it's an emergency treatment step. So the process map for clinical steps relates very much to WHO standard number 1. Let's talk about now, so assuming you've got a good understanding of evidence-based care, let's talk now about the health system drivers. And here again, what I've done is I have summarized each of the WHO standards that relates to the health system building blocks or drivers that will help you get to reliable evidence-based care. I'm not going to dwell on them. These slides are available for you, and also you should have access to the WHO standards. But there is if you just scan over this, very precise statements about what needs to happen at each one of these. What is the ideal state for effective referral systems? It's that we have appropriate referral information exchange, that it follows a pre-established plan without delay, and that access for the referral, the woman is assessed and a decision quickly made if she needs to be referred. These are very precise ideal states that give you the opportunity for setting an aim. Our aim is to do this, and then to measure a gap, and then to come up with some ideas and changes if you find that you're not at the ideal state. Let's switch quickly to measurement, and then we'll come back to how we actually generate these ideas. Here you can see that that there are 3 levels of measurement that we need to keep in mind as we're trying to track our way to our aims. Firstly, we need a measurement system that tells us whether the supportive health system is actually working. So these are standards 2 to 8. Are there data systems, referral systems? Are we engaging with women? Are our health workers appropriately skilled and motivated? Are our managers and leaders engaged? And do we have the appropriate resources? That's one level of measurement that is very often missing. There are many input measurements there, but there are a number of ideas that you're going to have that are strengthening the health system in order to be able to support the next level, number 2, which is reliable evidence-based care. So reliable evidence-based care will be taking us back to that process map. We'll show you how that works in a moment in terms of the measurement system. And finally, if we have a supportive health system, which leads to reliable evidence-based care, we know that we're going to get our third set of measures, which is the 50% reduction in maternal and newborn death and the measurable improvement of user satisfaction. So that's how the architecture of our measurement system that will support the architecture of our of the content of our actions that are going to lead to improvement. So let's just go down a little bit more granular, and I'm giving you some examples here on the process map. So these are the clinical process measures that will get us to our goal. As you see, I've given you just some arbitrary examples: percentage of mothers screened at the time of admission, the number of mothers, say, for instance, who are found to have eclampsia, who are then treated with magnesium sulfate. That would be on the treatment side. On the routine care side, you'd need to look, for instance, at the early postpartum routine care. What percentage of mothers are achieving the AMSTIL bundle, the active management of third stage of labor bundle with oxytocin. So these would be discrete measures that track your progress down this path, and it's a very good way of organizing both your changes and your measures. And sometimes we have linked measures. So we have one measure which starts off by, for instance, the AMSTIL bundle, what percentage of mothers actually received the bundle, and then you can look at an outcome, a linked outcome, what percentage of mothers got PPH. That's the best way to know that improvement is leading to improvement of process is leading to an improvement in outcome. And that's what we're trying to get at. We're trying to get to that outcome, and we need to be sure that the ideas that we're using, that we can measure that they are improving at the process level, but very importantly, can we tell that what we're doing actually leads to an improvement in outcome? This is just a way of saying, of drawing your attention to the fact that you can't do everything at once. You have to be able to prioritize. So I've just color-coded arbitrarily Red means like you've really got to do something about it. Green means things are going well, and orange means things are not going so well, but it's not top of your list. So you can then prioritize by measuring your system along the system of processes. You can say, well, what are we going to work on first? And typically it will be something that's dangerous. There's a significant gap in performance in a process or an outcome, but you can clearly link a process like I just said to you about the Amstel bundle to postpartum hemorrhage, something that's not too complex. At the front lines of care, we need to be working on simple cause and effect relationships between what we do and what happens, and that it's something that's in our control. This is not something that we need central government to make a change in protocol on. This is something that we can do tomorrow with a small group of patients and test out on our own. And one example that I would use to illustrate this is say for instance, you find in early postpartum care that you have a high incidence of postpartum hemorrhage and that you have a number of mothers who've died from PPH. That would be an example of a problem that you would say, this is our priority. The mothers who are dying, most are dying of hemorrhage, and there is something that we can do about it, making sure mothers get oxytocin immediately after birth, and are they getting it? So how do we generate these ideas? So the first thing is to take the problem right to the front line and make sure that the system and analysis happens at the front line. One of the biggest mistakes that is made in health system administration is to try to solve these problems at the level of the district manager, at the level of the facility manager. These problems need to be solved at the front line. And here you can see these nurses from KwaZulu in South Africa each one of them has a fishbone in front of them. They're analyzing their own system. They're coming up with ideas, but every great idea is not necessarily a great idea. And that's why we have the PDSA, and that's going to be what we're going to talk about at the next webinar, which is what do you do once you've got these great ideas? We need to put them through a planning system to make sure that they really do get implemented and that they are sustained. But that's what we'll be talking about next time. Let's briefly talk about the use of the fishbones, and I think most of the people on the call are probably familiar with this model. There are a number of ways of generating ideas, but this is the one that we use the most frequently. And what you can see here is that what I've done is that for each of the bones of the fishbone, I've introduced the WHO standards numbers 2 to 8. At the front end of the fishbone is your aim. The problem is that there are high rates of PPH and maternal deaths from hemorrhage. You would then set an aim, which could be a process aim if you're starting off, which would be every mother receives oxytocin within a minute of birth. And then you'd go back to each one of these health system support processes, categories, and then generate ideas for what might be done in order to be able to get you to the aim. So for instance, for resources available, just make sure that the oxytocin is in the hospital and available for use, etc. Let me give you a very quick case example before handing on to Ben. This is a program which I think some of you may have heard me talk about. It's a 13-hospital collaborative. These are all district hospitals in the central region of Malawi. 75 deliveries per year across the 13 hospitals, and an aim very similar to the network aim, which was to decrease maternal and newborn deaths and stillbirths by 30% over a 2-year period. You can see the 5 design elements of the network that I showed you right at the very beginning. Project aim, a very clear aim which has a number and a time. The content theory, which includes both the clinical processes, health system drivers. For this particular process, you can see all we did was we took the 4 stages of the patient journey and took the WHO recommended interventions for each of the steps along that path. If you can decide based on your country protocols exactly how to populate this list, and depends on what you're focusing on. In terms of the health system drivers, we didn't use exactly the WHO standards, but very close to them. So you can see these are very much the issues in the health system around leadership, activation, leadership of change, making sure the commodities are there, making sure you've got data systems that can reflect what you're doing, knowledge of the health workers, functional QI teams working at the front line, and then engaged knowledgeable mothers. These are all covered by the standards, but these were hugely important to be able to say, this is our theory, is that if we work on these health system factors, we will get reliable processes according to that map, and we will reach our aim. I'm switching now to measurement. These were the measures, and I'm going to leave these slides for distribution, but I want to draw attention to the extreme difficulty that we face in collecting the measures that are required for improvement. In terms of the Malawi project, I've put stars on the only measures that were available on the DHIS: maternal death, newborn death, stillbirth, and early breastfeeding. All of the other processes and the inputs had to be collected by the clinic teams, by the district supervisors with support from the local NGO. So, and the way that they collected it was by going to the registers, going to sampling the patient files, sampling the panographs, doing death audits, and pulling on pharmacy stock reports. This is a lot of work in order to be able to get this measurement system going to measure the changes that you're interested in for these processes. So we don't have time to discuss this in detail, but all I can say is certainly it is possible to do. We showed that it is possible to do, but what the huge opportunity we have is to engage with governments, districts, and certainly in the demonstration phase to test out systems of data collection and measurement that will support improvement, because I can guarantee you that in all 9 countries, these measurement systems do not today exist. I'm handing now over to Ben. Ben, maybe you'd like to just introduce yourself briefly.
Hello, can you hear me?
Yes.
Great. Hi, my name is Ben Nemser, and I'm working with WHO and the Quality of Care Network, working particularly on the monitoring and evaluation work with the Secretariat. Thank you, Priya. That was an excellent presentation. And just for the sake of time, I'm gonna run through some of these next few slides fairly quickly so we can get to questions. And I know everyone is eager to ask. So just the first slide here, just want to start linking this discussion to a bit of the broader learning agenda of the network and the monitoring systems. Pierre did an excellent job of articulating a lot of the learning that happens at the facility level with the frontline QI teams, but I also wanted to recognize some of the needs of the district regional. So learning across those facilities and communities within a particular district, as well as at the national level. So what does the national government and other partners need to learn across those districts to improve that national scale up? Because oftentimes some of this QI happens autonomously or uniquely within each of the facilities, and so how can we gather information through the monitoring system, to help understand what's going on in across facilities, across districts, and for that national scale up. Pierre, can you move to the next slide? So the network articulated a few different components within the monitoring system. You'll see off to the right, the columns really are sort of the user of the data or who's collecting that information, and then the rows are the different components. If you can click once, you'll see the first piece is a lot of what Pierre talked about in terms of those quality improvement measures, so how the facility teams identifying, making rapid improvements through data, through monitoring systems, and making changes to their practices. If you can click one more time. When building these information systems, as Pierre mentioned, a lot of the data isn't in those systems. So if we want to start tracking information across multiple facilities or across multiple districts, there's going to have to be changes maybe to information systems like DHIS2. Noting a lot of those things, strengthening those systems often take a lot of time and a lot of resources, so they need to be done fairly carefully. So when we're making those improvements and strengthenings, we need to consider what information the district managers need, as well as the national Ministry of Health leadership and other partners. So sort of looking at those other components around performance monitoring at the district and regional level, as well as some of those implementation milestones for the network goals in terms of the leadership and action and accountability. Then lastly, another component that the network is looking to develop is these common core measures. Here, the idea is to have some common measures that are tracked across all the countries of the network in a similar fashion, linking to a lot of other global work, whether it's the global strategy or every newborn action plan, et cetera. But really the idea is how can countries learn from each other? And then secondly, these common core will be gathered at the facility level, but can be used by the facility, the district managers, as well as the at the national level. So kind of having a thread that goes through all of the different actors and stakeholders within this network. And that work is sort of ongoing. We're hoping to have sort of a list for discussion with the countries in the next few weeks. You can go to the next slide. And then lastly, what is the network helping to provide resources to help build these monitoring systems and strengthen monitoring systems? First, we have going to have a web-based repository for these monitoring tools and guidance, whether it be validated collection tools or analytic methods. Secondly, providing technical assistance for this work as countries get going with their demonstration districts and trying to build that culture of quality improvement. Next will be a web-based dashboard for some of this information and tools to track performance. And then lastly, linking with other related initiatives. Many of you may have heard of the Health Data Collaborative, which is also working to strengthen health monitoring systems, as well as the Primary Healthcare Performance Initiative, which is looking at a lot of quality of care. So those are just a few quick things that sort of the monitoring team within the Quality of Care Network is working on, and hopefully can provide more information as these webinar series go on. I'll pass it back over to Pierre.
Okay, thanks, Ben. I think we may actually be running out of time to do the next module, and I'm going to suggest that we do a session on what I'm going to discuss next really is how we should be tracking data, particularly data over time at the facility level. But I think that what we should probably do, my suggestion, since it's now already 3/4 of our way through, is to open the session for questions, and then we can run another module on data at the front line, how to collect it, what to collect, and how to interpret it, very importantly, and how to learn from it as we go through. All the slides are available. There are a number of references at the end I would draw your attention to. If I could just go to the very last slide, which is, oh, I think I've overshot, but anyway, the very last slide will take us to a number of resources that are available. Here we go. And you're very welcome to contact me for any questions you have. So back over to you, Bene.
Yes, hello, thank you, everyone. Please raise your hand or type if you cannot hear me properly. Thank you, Pierre and Ben, for this excellent presentation. You got a few questions as you were talking. The first one is from Indira Narayan, who asked whether it would be helpful to have two more components included. One is that to organize practice, simulated practice at the facility level for health workers to be ready in case of emergencies. And on the other hand, the second one is to prepare communities and families to also be ready so they know what to know when they have to go to the facility. Over.
Yep, I'll just answer that very quickly. I just think that those are really two excellent practical suggestions. I think it's really up to, I think there's a broad category of a prepared health worker who is ready to act, and I believe that is part of that is emergency ready for emergencies, and we would certainly advocate drills and practices should be very much part of training the frontline staff. I love your idea about preparing mothers. I think this is a hugely important aspect. We're in Ethiopia. We are planning to try out some new ideas around giving mothers scripts. In other words, if you get into this situation, this is what you can say. Really just sort of giving mothers really practical advice about how they can speak up for themselves. And I look forward to seeing this whole field really emerge. But two really good suggestions.
Thank you, Pierre. The next question is from Tariku Keyalev. How is the network functioning towards uniformity of measurement across the 9 countries? You think that could become an issue, and even in the same country, different facilities have different tools for measurement?
I'll defer to Ben on that.
Yeah, that's a good question. That's a very good question. So I think that's the idea behind these common core indicators. Having just a small set, 10, 12 indicators that we can hopefully track uniformly across countries, knowing that each country has its own unique information system, sort of legacy systems, and sort of the stack of technology, whether it's DHIS2 or other HMIS, whether different types of health facility assessments, et cetera. We don't want to put a high burden on that, but we want to have some uniformity so that countries can both learn from each other and take up some of the sort of the tools and methods that have been developed, and so can kind of learn and jump in fairly quickly. So I think it's a work in progress, and we're working both with sort of global and national level technical advisors to kind of come up with those measures and see how they can be implemented. So look forward to providing more details on that in the coming few weeks and months.
Thank you. Another question from Ariane Ritsema. How does intervention deal with health worker motivation? Very often a major obstacle to good quality of care. And we had that question in all 3 webinars. It's one that participants really care about.
Yeah, this is so important. So my experience, it's interesting. One of the most exciting aspects about working in quality improvement is the effect that simple, actionable quality improvement actions has on the frontline staff. If you do this right, one of the great sort of cultural changes that happens in quality improvement is that in a way, you're moving the power of decision-making and action from leadership and management to the front line. And the frontline staff, first of all, they're involved, as you saw in that picture of the nurses that I showed you from South Africa. They're involved in every step of the way. They are deciding what it is that's not working by looking at the data. They're deciding what their ideas, and they're at the front line every day, so they actually do have the solutions probably much better than the management and leadership. They then take control over the testing process, and if you do it right, you show them back, or they see for themselves the data improving. That cycle has done more, in my experience, for health provider morale and motivation than anything else. It's certainly hands down better than any of the kind of inspection models or carrot and stick models that I've seen out there in order to try to either incentivize or de-incentivize or whatever from the top leadership at the front line. There's a lot of talk about, frontline workers just need to do what they have to do. Well, frontline workers signed up for this job for a reason, is that they love to take care of people. And we just need to give them the tools to make it easy to do that. And I'm very confident that this methodology, as I say, and certainly we've measured this, the affect of healthcare workers who are coming into an improvement collaborative process is very different to the affect when they leave. They feel empowered, they feel much more positive about their job. We've actually measured decreased rates of turnover of staff, etc. So I'm very up on just the process itself. One of the things that we didn't get to in this presentation, which you'll see the data at the end, we measured a change in the actual accuracy of measurement from the clinic just by doing the improvement process. So without actually paying specific attention to measurement quality, we measured a very, very profound improvement in measurement quality because the staff became interested in measurement just because they felt it helped them do their job. So as I say, I think quality improvement can really make a big difference to motivation, but that's also why you need to get leaders involved. If they don't think that their leaders really care about this improvement, you can forget it. They're not going to do it.
Thank you. As a follow-up question, Ariane suggested or asked if it would be an idea to include quality of the community-based maternal newborn health on follow-up and referral of pregnant women by CHWSS in charge. For example, the first problem in the example of the delayed referral from the community.
Absolutely, yeah. And so this was a very strategic decision that the WHO took, which was to focus on the activities in the facility. And I think any of us who have worked in this environment knows that you cannot separate the actions that happen in a facility from the events, surrounding events upstream and downstream that happen in the community. So I think this is just the start. I think getting your house in order at the facility is hugely important. And a lot of this thinking really came from the observation in the universal health coverage world that, you know, you can get a woman to a facility, but you better make sure that if you are putting a lot of effort into driving women from home deliveries into facility deliveries, that the quality of care that they receive when they come to the facility is good. And it's that philosophy, I think, that is driving the WHO decision to start this network activity on facility activities. But you're absolutely right. You know, most of the ongoing deaths that I've seen in that example that I showed you in Malawi, the 12 hospitals, maternal mortality decreased by 40%. The deaths that are occurring mostly now are deaths from mothers who came in too late, who didn't get referred in early enough, who did not know that they needed to come in, you know, when something like a bleed happened. So unless we address those community events, and certainly the survival of babies depends on what happens when they leave the hospital. You can't neglect that. So I think there's awareness that these are hugely important issues. It's just a strategic decision to start at facilities at the moment.
Thank you. We're going to take 3 more questions, and if you have more questions, it's not a problem. We will ask Pierre and Ben to answer them after this call and post the answers on the website, so feel free, but we only have time for 3 more. The next one is from Emmanuel Autolorin, who is worried about how to address lack of political will and poor accountability. He comments that there's always low-hanging fruits, but the difficult part is to access the high-hanging fruits with solutions outside of the health facility and required political will. How do you address that?
Yeah, what a great question. I agree. I think there is a sequence to this, and the reason we talk about going after low-hanging fruit is because people need to practice, particularly if you've not done quality improvement before. You need to practice quality improvement on something that's easy. You also then need to get encouraged by it. So the act of doing something that's easy, that you can see a quick win on, really gives people confidence that there really is some validity to this methodology, and it builds the will and belief of those who are more skeptical around to join and to start doing this work and to participate. And it builds the motivation of others around to join in. The beauty about the network design is that it's designed at facility level, at district level, and at national level. And we were on a great call this morning with the Ghana team, where the government is really leaning in and getting engaged and preparing the way to address the bigger, more complicated system issues that will inevitably be the roadblock. I mean, you saw in that example I showed this morning, there were issues around simple process, getting, triaging at the front line, getting the right woman in. A woman in late labor shouldn't be waiting 2 hours. A woman with meconium staining should be under high scrutiny. That baby ended up getting asphyxiated. They should have kept a closer eye on that mom and maybe acted sooner. Then the electricity went out. Well, everything up to that point could have been addressed by process change at the facility level. You can't change electricity blackouts, okay, at a facility level. That is at a district and national level. But the good thing about this WHO design is that there is an interlinking, specific interlinking, that, and they have, the WHO has done a fantastic job of engaging national teams, and I'm very confident that this is going to be very different to project-like activities that I've seen before, where you try to solve something in isolation of that larger political and systems context that you're talking about.
Okay, thank you, Pierre. A question from Asha Poon. I'm sorry if I don't pronounce the name properly. Who comment that when there is no flexible fund to address small issue in a hospital, often health workers will get discouraged because they won't see any results. So Asha suggests maybe block grants for the hospital to be able to implement the action plan that results from an assessment.
I think from the question, I think what you're talking about is like autonomy, like you have, first of all, resources to be able to address some of the more frustrating resource-based issues. I think that's a really great suggestion. Some of the, you can have the best process improvements in the world, but if you don't have the drugs, you can have a reliable process for giving mothers oxytocin, but if there's a supply chain issue for no oxytocin, you're going to see no improvement. And we see this over and over again. And I am very aware of how big of an issue this is in the countries that we're trying to work in, the 9 countries. And so that's why I think a block grant sounds like an interesting proposal. I think that this network is going to show the way really in how to address these more complex issues around resources, autonomy, which I think is a really interesting idea about hospitals taking responsibility, or clinics taking responsibility for their own local environments, but then giving them the resources and the responsibility to do that.
Thank you. And the last question, I see more coming in, and we'll answer them on the website. From Vikas Trivedi, who say, from his experience, the culture of data works best. Any comments for Ben, probably, that in addition to the outcome measurement, will there be focused learning on such indicators? So I suppose it's focused on learning and not just outcomes.
Yeah, Ben, do you want to take that?
Yeah, and I actually could kick it over to Vinay a little bit with the learning platform if you want to plug that. But yeah, I think the culture of data is really key, and I think Pierre hit on it during his presentation, which was building that at the leadership level, not only at the leadership at the facility level or district level, but also at the national level and global level. So I think the network, will provide the necessary tools and environment to both take that data from an outcome level, to look at the clinical and medical outcomes, but also, work with the national and district level to, again, build that culture and then really understand how to use that information to affect change, both at the political as well as financial level.
Yes,
and say anything about the learning platform?
Yes, one of the key components of this network is the learning platform, whereby, as Ben just said, is not just about the clinical outputs, but also how to spread the quality improvement and how to learn from mistakes and from results. So a lot of it is about not results, but how to get there, what went right and what went wrong, and how to inform other decisions and other projects. So that's still in the making, and this webinar is part of it. And it's not just the hard data either. It's a lot of the know-how and knowledge and ideas that people have that are, stories or more difficult things to document, and that the network is trying to capture. Okay, I will stop here because I see we have no more time for the reminder question that Ben and Pierre will answer offline. So I'd like to thank everybody. As always, in this webinar, we'll be sending the recording of the session as well as the presentation in the next 2 days to all the people who attended. We also post everything on the website. We'll send you a link to that. On the website, again, you have the chance to ask more questions if you have follow-up questions. So feel free, there's a question and answer there, and we answer everything. Thank you very much to Pierre and Ben and to Wilson for introducing the session. And thank you. Have a nice rest of your day.
Thanks, Benny. Thanks all.
Thank you, everyone.